Dear friends, I am thrilled to announce that Professor Rüegg, an expert in tumor vascularization, has kindly agreed to prepare a lecture for us. The lecture will delve into the similarities between tumor neovessels and retinal neovessels. You will be surprised at how many concepts relevant to ophthalmology are conveyed by the professor. He will discuss a range of factors that stimulates neovascularization in both physiological and pathological contexts. The lecture will cover the unique morphology of this vessel, which are fragile, lack endothelium, and consequently leads to edema, hypoxia, hemorrhages, and necrosis, as we also observe in the retina. On the therapeutic side, the lecture will address the challenge of primary and secondary resistance to anti-VEGF agents. This resistance explains many negative responses to our intravitreal treatments. Certainly, we need to step out of our comfort zone a bit, but listening to the lecture multiple times will prove valuable. What an interesting and useful journey it promises to be. Toward the end, our friend Riccardo Sacconi, recipient of the Paxi Medal 2023, will outline the utility of the interdisciplinary oncology ophthalmology approach in a brief video. But now, let's turn the floor over the pathologists.
Yes, I wish they could have been with you today and shared this very nice conference, but unfortunately I couldn't make it, and I'm very happy we can do it electronically. I would like to thank you very much, Filippo, for the invitation, which actually was a kind of a surprise because this is not really my topic. So macular degeneration, I find, is a very, very, very interesting subject. And I was asked to give a short talk about the contribution of tumor angiogenesis, or at least what we learned about tumor angiogenesis that could be relevant to you. And this is actually what I'm doing. So I'm not sure I put up myself this title. It's very ambitious. I'm not sure we'll answer all what is in the title, but I hope I can give you a short digest of what we learn. Actually, what I'm going to do is to share with you in this 15-20 minutes what have we learned from tumor angiogenesis, which has been a topic of my research for several years. What have been learned that could be useful in other fields, or at least in general, about angiogenesis in pathology. And I must say, tumor angiogenesis is actually where all it started in a way. Because that was the main interest. So mechanisms could be applied or could be useful to understand phenomena in other pathologies. So we will give you 3 points. One is about biology of what we learned in tumor angiogenesis, about unsolved questions, so questions which are really basic and we still don't have a final answer, and then some outlooks at the very end. And I hope some of these points will be useful to you for your research and your clinics. So the original actually observation about tumor angiogenesis is that the tumor are vascularized. And you can see here in red, endothelial cells stained in red, and in green you see macrophages, so inflammatory cells. This seems obvious now because we all know it, but it was not always like this. So this was discovered in the early 19th century, and then later on in the 70s, Dr. Judah Folkman actually revitalized the field. And the reason why it is interesting, it has a clinical phenotype. So the more angiogenesis is present in a tumor here in red, the worse the outcome for this particular cancer is. And this is mostly true for all cancer, with some exception and some grading. But I think this is an important message. The more angiogenesis there is, the more aggressive the tumor will progress. So this is the starting point. Now, how does that occur? A second discovery is that soluble factors, actually factors produced somehow and somewhere in the tumor environment, induce angiogenesis. So tumors start avascular initially, Then there is an event that we call angiogenic switch. I will come back to that in a slide. And following this angiogenic switch, actually, new vessels start to spot out of existing vessels and invade or surround the tumor in response to release factor. This kind of candies here, you see in different colors, are actually growth factor. There is a plethora of growth factors that can be produced, and this is a complication of the field. We know about VGF, but there are many others actually that are angiogenic, and basic FGF, so fibroblast growth factor, actually was identified even before VGF as a vascular factor. And here you have two tumors before and after the angiogenic switch. This is a genetic model, the RIB1TAC2 mouse model of Daghanahan that we have been using also in the lab. So there is a time, the message is there is a time during tumor evolution that angiogenesis is switched on through factors, through soluble factors. But that's not the whole part, the whole story. Cell adhesion plays an important role, not necessarily to induce angiogenesis, but to stabilize it. You create new vessels, and this vessel has to be stabilized. This occurs with adhesion events between endothelial cells. I mean, these gray boxes here, cell-to-cell adhesion events, and cell matrix events on the basolateral basal side. And these events are mediated by different adhesion receptors with different properties and different functions. So the cell-to-cell adhesion is mediated physically. So what keeps the strength are cadherins. They are then hooked up to the intermediate filaments and to act in cytoskeleton. So those are the ones that take the mechanical strength. And then you have gap junction for cell-to-cell communication, and what we call tight junctions, which are contains GEMs, junction adhesion molecules, or claudins. They make the endothelium tight. So these are responsible in part with cadherins to keep vessels tight and avoid permeability. And then on the basal side, we have integrins that are attached to matrix proteins. And we have also pericytes, and the interaction with pericytes is a bit more complicated. In part is through matrix, and part is to cadherin, but not V cadherin, is mostly N cadherin. What is important to know is that they are not stable elements. They are very dynamic elements, and for instance, in response to VGF, these junctions can be disrupted. And by the way, VGF was discovered by Hal Dvorak before Napoleone Ferrara as vascular permeability factor. So when you have angiogenesis, inflammation, permeability increases, which could be interesting to the macular degeneration. I mean, the angiogenesis and the tissue remodeling there. So these are kind of the mechanism, to keep it very broadly. Now, what turns actually, what is upstream of this angiogenic switch? And we certainly all know hypoxia that induces angiogenesis, but that's not the whole story. There are three big events. One is the genetics for the tumor, at least. Genetic events, I mean, like oncogene and tumor suppressor, they regulate angiogenesis. So the initial idea by Dr. Folkman that this is a genetic independent effect is actually not completely correct. So the genetics activation of oncogene actually induces angiogenesis. Then we have inflammation and other stromal events, which are probably even more dominant than the tumor genetics in inducing angiogenesis. And I'm coming back to that because, again, it's probably relevant to your pathology. And last but not least, is hypoxia, which certainly contribute, but it's not an early event. This comes rather at a later time point. And to complicate matter, actually, these events interact to each other. So the genetics certainly, if you activate RAS is a tissue repair pathway. So you activate signaling ways that induce inflammation. So there is a link between the two. There is also a link with hypoxia. So to P53 and HIF, they crosstalk. And then hypoxia causes inflammatory response, HIF signaling. So this is important to realize that it's not just hypoxia, but there is much more, and probably the top event is inflammation. And inflammation, you know very well that is a complex multicellular, multifactor event. Is a very complicated cascade with back and forth pathways. Simply said, in oncology, we can say there is a communication between cancer cell and inflammation, like oncogenes induce inflammation, but then inflammation also promotes cancer growth with a number of factors that event, promotes cell motility, survival, and metastasis. Inflammation promotes angiogenesis through stimulation of endothelial cells and promotes also tissue remodeling and fibrosis. And as far as I've read about macular degeneration, there are elements contributed by inflammation that then promotes disease progression. So the message here is that you cannot dissociate angiogenesis with inflammation. These two pathways, they really communicate. And we know now a lot about cells that actually modulate inflammation and angiogenesis, and not just the simple, non-specific and inflammatory cell like PMNs or monocytes, but also lymphocytes. Different type of lymphocytes contribute to that. As an example of how many inflammatory cells there are in the tumor, in a tumor situation, all colors here except this pale red are non-tumor cells within a tumor. You can analyze with this multicolor system like Codex and others. So every dot here, every confetti is a non-tumor cell present in the tumor microenvironment, and every cell that you see more or less as property to induce angiogenesis. So there's really a very intimate, very strong, very constitutive link between inflammation and angiogenesis. And the last thing, I won't go into the genetics because I think it's less relevant to you, but the last point is hypoxia. You know the HIF pathway, which ends up in a transcriptional activity to express a number of genes. The system is normally silent because the transcription factor is degraded in the presence of oxygen, while it's activated in the absence of oxygen. It's a real nice system, by the way, that uses the target to activate, so oxygen to activate the system in a molecular biochemical way. You have certainly angiogenesis. I mean, this is one important outcome of this activation, but you also have metabolic adaptation, and this comes back to what we call tumor resistance in a second. Survival, so resistant to apoptosis, but also cell motility. So it's a tissue remodeling factor. So once you get hypoxia, things get really complicated and very odd and very, 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 they go a kind of accelerated pathway to a bad prognosis. So hypoxia in a tumor situation is a negative sign for progression. So it's correlated with progression and reduced survival. Now to end this part, so how do these vessels form? This is also, we learned a lot from the tumor angiogenesis part. So most angiogenesis is done by sprouting. It's not the only mechanism, but it's the dominant one. And sprouting means you go from an established vessel, which should be down here. Endothelial cells get activated, they migrate out. And there are some hierarchies in there. As you see here in green on the right side, these are the green cells are tip cells, which are the pink down up here. They are very sensitive and responsive to VEGF or other angiogenic factors. They're kind of sensors. They like a growth cone in a neuron. They sense a gradient and they migrate and they pull cells that do not sprout, but proliferate first, and then they become quiescent. These are stalk cells. So you really go out like a finger and the arm, and eventually the structure, these solid cords are vascularized or are luminalized. So you have a lumen, and they are stabilized by pericytes and by matrix and by a wall. There are then very complex feedback mechanisms like PDGF, TGF-beta, and the angiopoietin system to stabilize the wall, but also the notch system to prevent that you get sprouting everywhere, so you get a hierarchical system. So this is the good side. I mean, this is, when things go well. The problem is that in a tumor situation, in a chronic angiogenic situation, things don't go that well. And here again, oncology or tumor angiogeny learned us a lot, and I think you have similar events in the macular degeneration. The key message is that tumor vessels or angiogenic vessels that don't get quiescent again, so in a chronic stimulation, could be also a chronic type of inflammation, don't go through the full circle of maturation. So they don't form very hierarchically structured networks like here on the left side, where you have arterioles, capillaries, venules, postcapillary venules, and then venules. So this is a very hierarchical, very organized, very efficient system. So an angiogenic system is very chaotic. You have loops, you have dead ends, you have vessels that go, capillaries go anywhere. They are highly permeable, so the endothelial cells are not tight, or they don't form this nice junction that I showed you before, and as we can see in normal vessels. So that means that these vessels are not very functional, and this is a main problem for the tumor biology then. One reason of this instability or this non-maturation is that the non-association or the limited association between endothelial cells in green and pericytes, which normally get tight, and the two cells stabilize each other through angiopoietin, PDGF, TGF beta, and so. In a tumor chronical situation, they stay apart, and the result is that these vessels are very fragile. So this is the system I was just mentioning. They are very fragile and very heterogeneous in their function. They break easily, so you get hemorrhages inside of the tumor. If you try to perfuse, like it has been done here with red and green molecules like liposomes or lectins, you see that while the normal tissue around is more or less homogeneously perfused, the tumor island here is not. There are black holes, so blood legs, which are not perfused, regions which are partially perfused, regions which are highly perfused. And the corollary of that is that you create heterogeneity within a tumor or in a tissue, uneven perfusion. You have regions which are starved, regions which are hypoxic, necrotic, and if you try to deliver drugs, chemotherapy won't go everywhere. And this is one problem, and coming back to the therapy. Then you have increased permeability, you have edema. I realize you also have in the macular degeneration that edema and an accumulation of vascular liquids. And they are fragile, they are unstable, and they bleed. They do small hemorrhages, which is actually a symptom. For instance, for colorectal cancer, bleeding is a symptom which is due to this fragility of these vessels. And then the total paradoxic situation, which you would not expect, you could think, okay, I have a lot of vessels. Yeah, they're not fully performing, but at least they should compensate hypoxia in a way. And this is a big paradox. Because of what I just said, the functionality of this vessel is so that you have within a tumor, in spite of high vascular density, so the green islands are vessels, and the red regions are hypoxic regions that you can stain in vivo with pimonidazole. Is a chemical that binds under hypoxic condition, and you stain with an antibody. So the red parts, the red areas are hypoxic. And again, this is not good at all for the tumor biology. You will activate HIF, you will activate cell motility, survival, metabolic rearrangement, and if you are a tumor, you start spreading and doing metastasis. So this is one of the main paradoxes of the angiogenic response, that you have a lot of vessels, they are not functional, and you get anyway an hypoxia and necrosis. And you can measure actually the PO2 that goes down to 0, so on the right part, and the pH, which is interesting, it moves down, so it still decreases after PO2 is 0. So you get an anaerobic metabolism, you generate lactate. So these cells are still viable, but highly hypoxic, so anoxic. And they have high HIF activation. And these cells in a tumor situation, they're probably those that are metastatic. So they are somewhere here in the rim. Now, the last point. So I thought about oxygen and metabolism and so, but endothelial cells also are cells like any other cell. So they also produce factor, they interact with the environment. And this interaction, we call it paracrine. It's a topic that came up, I think, 15 years ago by Shaheen Rafi, actually, in New York, introduced this term. So it's a non-metabolic, non-nutritional communication or function with the surrounding through factors. And in the tumor biology, there are some important corollaries. One is that this paracrine function, for instance, suppress the immune response, T-cell response. Now we know immunotherapy tends to break this, but vessels contribute to this immunosuppression. And combining, for instance, anti-angiogenesis and immunotherapy, so checkpoint inhibitors, seems to have synergistic or at least additive effects. Then the whole question of the dormancy, so how the vessels regulate tumor cell survival in time. Without going into the details, because it's a very peculiar to tumors, but one should consider that vessels are not just provider of oxygen, largely insufficient, provider of glucose and metabolites and removing metabolic products, but they are also cells that communicate through factors, through cytokines and so with the environment. Okay, so this is the biology part. I hope it gives you a kind of a dimension of about this phenomenon. And again, would really like to say that tumor biology, tumor angiogenesis provided most of this information that we know today and we take for granted, which was not the case like 30 years ago. So where do we go from there? This is an historical experiment that Napoleone Ferrara published back, I think, in the mid-90s, using what became Avastin. This A461 is the precursor of Avastin. It's still the mouse antibody. Was not yet humanized. And what he did, he grafted a tumor that he let go in a mouse, that he let go untreated. Then he treated the mouse with Avastin, the precursor of Avastin, that recognized human VEGF produced by the tumor. And you got only partial inhibition. And when he added a so-called trap, so a soluble FLT1, so it's the VEGF receptor 1, which has high affinity for VEGF, it can block mouse, so stromal-derived, and human tumor-derived VEGF. So human blockade and mouse and human blockade. And then you block everything. And you get really small tumors and non-angiogenic tumors. That tells what I said before, that non-tumoral derived VEGF, like inflammatory cell-derived VEGF, is an important element of the angiogenic cascade and the angiogenic switch. Nevertheless, this started it all, and the rest is history. So Dr. Folkman in the 70s revitalized. He didn't discover, but he really made very key experiments. Then Doug Hanahan established this angiogenic switch with this Ribuan-Tak2 model. And then in the VEGF was cloned at UCSF in the late 90s. And then at Genentech, mid-90s, Avastin was produced. I mean, all the studies were done. And in 2004, Harvitz published the first paper in colorectal cancer where he could show a modest but significant improved survival. So these are the two key people. Dr. Joe Folkman sadly passed away already, and Napoleone Ferrara is no longer at Genentech, is Southern California doing academic research. He's a very, very nice person. So it was a breakthrough in cancer therapy, but was unfortunately a big deception. So it helped Roche to make, a lot of money. So I think they were selling about 2 billion a year in the first Genentech Roche. In the first couple of years, still a hot runner, but less. So there are some benefits. You see that by adding bevacizumab to chemotherapy, you improve progression-free survival. So you have a response, but late patients relapse. So there is a resistance mechanism that comes into place. And these are There I will come with two hypotheses, with two elements. And even less, we still have a problem in understanding how resistance develop and what I mean. We have a lot of knowledge, but it's still not clear in the clinic how that works. So how do we think that angiogenesis or anti-angiogenic works? Well, the simple-minded hypothesis is probably derived from what I told you. If angiogenesis helps tumor to grow, if we inhibit angiogenesis, then the tumor won't grow, which is true, but it has some problems. So this vascular regression hypothesis, it will create hypoxia. So you will start the tumor, you will create necrosis, and this will create an inflammatory response, will activate HIF, and probably promotes a secondary round of tumor progression. So that has been very, very deeply debated, and is still a matter of discussion. The second hypothesis provided by Dr. Rakesh Jain is that you normalize vessels. So you actually trim and prune this excessive abnormal vasculature I showed you at the beginning, the black and white picture. So you retain only functional vessels, so those that are stable, that have pericytes, and that goes with increased perfusion and increased oxygenation, increased blood delivery. And that could be a reason why chemotherapy synergizes with anti-angiogenic drugs. And then the third hypothesis, which is very difficult to prove, is that one may impinge on this angiocrine direct effects, like any cell-to-cell communication. So these are three hypotheses, and probably there is a mix of the thing. But it's just to tell you that it's not as simple as that to fully understand how that works. Now, even worse is about resistance. So first of all, not all tumor respond, and in the macula, as I understand, is the same thing. Not every patient responds to anti-VEGF, to Lucentis or Avastin or whatever. And those who respond, at a certain point, they can develop resistant mechanisms. The tumor, in our case, start growing again. So there are, again, many hypotheses. There are probably alternative angiogenic factors which are produced in response to the hypoxia. Secondary inflammation to necrosis, following necrosis, with many angiogenic cells being recruited. And then tumor cells can be either selected or they adapt to the new condition, especially metabolic adaptation seems to be an important rewiring within the tumor, which then could promote survival and progression. EMT, so epithelial transition, motility, they're all associated with that. Genetic resistance is you probably select cells which were there before. But I think the most important point among all is that the tumor or the tissue could be the case for you too. The tissue around the inhibited vessels won't stay silent. So by nature, tissues react, respond, adapt, and that complicates matters. So it's not just a matter of targeting the vessel, but it's the tumor, how it responds. And this comes to an important point, how to measure, to monitor actually angiogenesis and the response to angiogenesis. Business with biomarker, which has been a very frustrating business. We have been trying with some ideas, but it's not so easy because you have to imagine you have multiple layers. We are not targeting tumor cells directly, like with chemotherapy, but we start before. So first you could monitor whether the cells, the endothelial cells, respond to the therapy, whether this response will translate to some effect on the tumor, so a tumor response, and whether eventually you get a benefit for the patient. And this is a really complicated thing. So you can address this at different levels molecularly, which gives you a part of the response, biologically to see how these cells behave. And this is where we mostly did our work. And functionally, mostly imaging, perfusion, you can see how the vessels function. But eventually it's the clinics. I mean, how is the disease, how does the disease behave? Is patients feeling better? I mean, the visus improves, so the tumor is regressing or stable. I mean, this is the real outcome. And to discern or to dissect, to monitor these other events is all but simple. Now, coming to an end. I mean, you probably got now an idea that, it works, but it doesn't work as well as we thought. And we don't even know exactly how it works. So it's not an easy situation. So where do we go from there? The field is moving toward new anti-angiogenic drugs, and mostly in combination or multi-targeting agents. For instance, there are multiple drugs that target multiple VEGF receptor or multiple PDGF receptor or multiple receptor kinase, whatever. Targeting this adhesion receptor business, so the structure has been a very frustrating business, but I think there is room for hope. So adhesion receptor and vascular wall, this is something that can still be explored. This angiocrine activity, it may be addressed with different means than anti-VEGF, especially that could avoid hypoxia, could interrupt communication without causing hypoxia. And in cancer, one therapy that has been associated with anti-angiogenesis is metronomic therapy. So you give it on a regular chemotherapy, you give it every day at low dose, and it avoids necrosis and has some tumor control activity. The second thing, which I think is much more interesting, is to target the reactive tumor or the reactive tissue in your case. Clearly, inflammation is a very important target, and now there is more and more coming in, like with anti-IL-6 or anti-TNF. This could be combined with anti-angiogenic chemokines. This is something we are working on. We have some interesting results. Anti-immunosuppressive or immunotherapy. This is ongoing, combining checkpoint inhibitors with One could also prevent this motility metastatic response with like c-Met inhibitors or anti-integrins. Anti-integrins have been very frustrating and very deceiving, but maybe there is something one could still explore. And then this last part, which is the metabolism. I mean, metabolic stress, oxidative stress, hypoxic stress, acidosis, autophagy. These are all mechanisms that favors tumor escape of tissue resistant to anti-angiogenics. I'm basically done. I will leave you now with outstanding questions more from a research point of view. I think some of the failures, I don't know how, I know that there are some models for macular degeneration, but I am not very familiar with. In cancer, there are zillions of models. The question, are they good? Because if you use the wrong model to ask a good question, then the answer is probably not the best one. I think we in oncology has to do improve models, and in particular to look more for metastasis and not primary tumor, because it's where we actually apply angiogenesis in the clinic. And funnily enough, or paradoxically enough, angiogenic drugs are mostly tested on primary tumor, which is, of course, a limitation. Then to better understand this adaptive tumor and host response from the tumor cells or the microenvironment. So this would also concern you, the inflammation immune response. I think we have still to learn quite a bit. And eventually test new agents and combination. Once we know from that, see what combination would be the winning one. Like in oncology, I mean, you cannot treat a tumor with one drug. And I think complex event, complex biology, you cannot just treat it with once, because you have this biological, is part of evolution to escape death. So you have probably to target several ways and pathways in oncology. I think we have some success there. And last but not least, I still think that knowing how good you target angiogenesis would be beneficial to any field dealing with angiogenesis and angiogenic therapy. The field is improving very slowly. Hopefully one day we get some universal type of biomarkers. We'll see. Time will tell. So I will leave you with this. So here you have so this is what we call the tumor microenvironment, a tumor cell and what is around. So these are all these confetti pink cells, color cell that I showed you before. You have vessels, endothelial, so vascular vessel, lymphatics, all inflammatory cells. You have matrix, you have fibroblast. In case of tumors, you also have adipocytes. You probably don't have that in the eye. And is this global interaction that will eventually determine the tumor fate. And probably in your case, I would be surprised that it's very different because you will have different cells and each cells communicate, crosstalk to each other. And it's a matter to understand what is going on and then to find the weak point to intervene. And I would like to remind that angiogenesis is also dependent on the bone marrow. So there are factors and cells that come in from the bone marrow. So it's a systemic, the tumor disease is a systemic disease to start with, probably not with the macular degeneration. But I don't know, you will probably tell me. So again, the message is that it's a big village. I mean, you cannot just look at one cell. You have to look at the whole thing together to try to understand what's going on. And this is the end of it. I mean, the end of my presentation, not the end of the story. Again, I would like to thank you for your attention. This is the group. We have some fun sometimes. I mean, success, failures has to be nurtured with some fun. Funding agencies, which are very thankful for that, and then patients, since we do some clinical translational studies.
Good morning, everyone. I'm Riccardo Sacconi from San Raffaele University in Milan. I had the great pleasure to listen during the 4th Parkside Center Retinal meeting in Bellinzona, this fantastic lecture of Dr. Rüegg Curzio about the angiogenesis in oncology of the tumors. I think that it's a great lecture because when we see this kind of angiogenesis of tumors, it seems to see something about angiogenesis in age-related macular degeneration because the analogies are a lot. In fact, he showed us that angiogenesis in tumor is driven mainly by the VEGF, and it is caused by 3 main causes. The first one is the development of hypoxia. The second one is the development of inflammation. And the third one is the genetic background. And this is very similar to what happens in age-related macular degeneration. When we have this neovascularization in this disease, we have usually hypoxia due to the reduction of the choriocapillaris and other plexuses of the retina and of the choroid. We have an inflammatory background. In fact, if you think that the new drugs for geographic atrophy are mainly targeted to reduce inflammation, and we know that we have a great genetic background also in age-related macular degeneration. So the same kind of environment in both tumors and neovascular MD. In tumors, the main driver is angiogenesis in which it is done by the sprouting of endothelial cells. This is very responsive to the VEGF, but when we have the development of this sprouting of small capillaries, these vessels are usually structurally abnormal, immature. They are chaotic in their growth, in which capillaries go everywhere, and they are immature and so permeable. And this is what happened also in neovascular age-related macular degeneration. For example, when we have the development of neovessels and when we perform OCT angiography, we can see that in neovascularization in MD, we have a very dense neovessels with a lot of capillaries, abnormal, very permeable. And for this reason, we have, for example, an increased permeability causing edema in both the tumors, but also in neovascular age-related macular degeneration. And in both diseases, tumors and MD, this sprouting of neovessels results in immature and fragile neovascularization. capillaries. And for this reason, they could cause also bleeding. But the paradox of tumors is that we have a high vascular density, but there is again a hypoxia. Why? Because you have a high number of vessels, but these vessels are immature. And so they are not able to give a response to hypoxia. And for this reason, there is again hypoxia. And this is less or more what happened in neovascular age-related macular degeneration. We have a great growth of capillaries, this sprouting of endothelial cells, but this growth is chaotic and they are immature. And so they are not able in this way to respond to the hypoxia of the RP cells and of the photoreceptors. The last part of the talk of Dr. Rüegg was about the use of anti-VEGF in the treatment of tumors. There are three main hypotheses in which anti-VEGF works in the tumors. The first one is inducing a vascular regression of this sprouting of neovascularization. The second one is inducing a vascular normalization of this neovascularization. And the third one is a direct effect on the tumor cell. We don't know if there is mainly one of these three hypotheses in tumors or if there is a mix of these three hypotheses. And this is less or more how it works also in neovascular age-related macular degeneration. But I think that there is a main difference because our target is not to delete of all novessels in MD, but is to induce some kind of maturation and normalization of the neovascularization. In tumors, you would like to have a complete regression of the neovascularization because you would like to have a death of tumor cells. In age-related macular degeneration, you don't need to have a death of cells because you would like to preserve RP cells and photoreceptors. And in this way, if you are able to have a maturation and normalization of the neovascularization, in order to reduce the immature capillaries, but inducing some kind of mature vessels driven by, for example, arteriogenesis, you can have this neovascularization that could give nutrition to RP cells and photoreceptors in order to preserve the outer retina from the geographic atrophy. If you have a complete death of neovascularization, this results in the death of RP cells and photoreceptors and so geographic atrophy. In this way, you would like to avoid this scenario. So I think that we need to understand and to listen better this lecture of Dr. Rüegg because it is very interesting in order to better understand the molecular mechanism in tumors that are very close to what happens in neovascular age-related macular degeneration. Thank you very much. Bye-bye.